everyone. I am Dr. Jigisha Pujara, Professor in Cardiac Anesthesia at UNMICRC Institute of Cardiology and Research Center, BJ Medical College, Ahmedabad. From this month, we are going to start Ecmo series. From this first, we are going to speak about the extracorporeal membrane oxygenation, basics and the history. Extracorporeal life support (ECLS) is the main term used to describe prolonged but the temporary support of the heart and lung function using mechanical devices. It is often erroneously labeled as the extracorporeal membrane oxygenation and now is very popular this terminology only. So we'll speak only about Ecmo in our further lecture. Ecmo is indicated as first line of the mechanical cardiac and respiratory support in acute severe reversible cardiac or respiratory failure when the risk of dying from the primary disease despite the optimal conventional treatment is very high. Overall, Ecmo defined as a technique developed to ensure a prolonged but temporary support of the heart or lung function in patients suffering from reversible cardiac and or respiratory failure using mechanical assist device. ECLS can be used in a veno-arterial VA mode, veno-venous VV mode or arteriovenous AV mode. There are various terminology for the ECLS. ECLA, first of all, is CPB, cardiopulmonary bypass. It is used in the operation theatre for the various cardiac surgery. ECLA, extracorporeal lung assist, extracorporeal technology used for only respiratory support. ECCO2R, extracorporeal carbon dioxide removal. It is used only to get rid of the CO2. Oxygenation will be taken care of by the ventilator itself. VAD, ventricular assist device, used only for the cardiac support. LVAD, left ventricular assist device, used only for the left ventricular support. RVAD, right ventricular assist device, used only for the right ventricular support. BiVAD, biventricular assist device, used only for total cardiac support, both ventricle. ECPR, extracorporeal cardiopulmonary resuscitation. It is used for patients in the cardiac arrest as a resuscitative measure. Now CPB versus Ecmo. When the heart and or lung machine used in the operation room in a veno-arterial mode to provide total support of the heart and lung function to facilitate the cardiac surgery, then the technique is called cardiopulmonary bypass. Basic technology of the Ecmo is originated from the CPB only, and extended CPB later on lot of modifications developed and make quite different from the CPB. In CPB, total bypass is achieved, while during the Ecmo, the partial bypass is achieved. There is difference between CPB and Ecmo. CPB location is operation theatre for the heart surgery, while Ecmo it can start at the operation theatre or in the ICU, and extended Ecmo is in the ICU for the critically ill patient. Type of the mode is here in the CPB, total VA bypass, while in the Ecmo it is VA total or the partial, veno-venous, VV, veno-arterial, VA, veno-arterial venous, veno-venous, veno-arterials. There are a lot of modification occur with the Ecmo. Equipment used in the CPB are large venous reservoir is used, while in the Ecmo usually no reservoir or the small beta bladder is used. Heat exchanger, large heat exchanger with the water bath required for the hypothermia in case of the CPB, while in Ecmo small heat exchanger only for the warming of the blood. Roller pump is used in the CPB, while centrifugal pump is used in the Ecmo. Arterial filter is used in CPB, which is not used in the Ecmo, and hollow fiber oxygenator used in CPB, while usually plasma tight or the membrane for the prolonged use is used in the Ecmo. Cannulation, largely central cannulation in the CPB. Sometimes in minimal invasive or the robotic surgery, there will be the peripheral cannulation is used. While in Ecmo, usually preferably peripheral cannulation, either carotid or the femoral, and sometimes central cannulation are also used in the Ecmo. Heparin used is large dose in the CPB, 300 to 400 units per kg, while in Ecmo it is lesser dose is used, and acetate required to capt is more than 480 in the CPB, while here in the Ecmo it is 180 to 200 second is more than sufficient. Autotransfusion is done is a suction is done in the CPB while is not done in the Ecmo. Hypothermia maintained to prevent the myocardial damage and to maintain the oxygen delivery consumption ratio in case of the CPB while it is not required in the Ecmo. Usually hematocrit is required 27 to 30% as there is a hypothermia, metabolic requirement decreases, so even low hematocrit is good enough in case of the CPB, while in ECMO we usually required to keep the hematocrit 35 to 40%. Left ventricular contractility is maintained, not maintained in the CPB, while in ECMO it is must to maintain the LV contractility. The time concerned is minimize the time of the bypass. It is mostly few hours, while in the CPB, while in ECMO it is maybe it's days or weeks also. Weaning is a few minutes to few hours in the CPB, while in ECMO it is few hours to few days. Basic principle, it works on the principle of replacement therapy for heart and lung or both. Hemodialysis for the renal failure is similar, like here ECMO is for the heart. Unlike ventilator and inotropes, which works through the native lung and the heart, it works through the different pathways. Blood drains from the patient through a tubes or catheters placed in a large vein. This blood passes through the tube and then it pumped by a mechanical pump, which is centrifugal pump, which serves as an artificial heart. This heart pump provides necessary force as a blood pressure for the blood to circulate without and within the body. This blood is then diverted inside the tubing to an artificial lung respiratory filter for the oxygenation and removal of the carbon dioxide, that is through the membrane. The blood is then passes through the heat exchanger, maintain the blood at normal body temperature, and this finally heated warm blood re-enters into the body through the large arterial catheter placed in the artery in the neck or the leg with the pressure and the oxygen to perfuse and ventilate the cells of the body. Thus, the artificial lung, membrane oxygenator and the artificial heart, that is centrifugal pump, take care of the tissue perfusion and oxygenation irrespective of the contribution by the native organs. This takes away the entire load of the gas exchange from lungs and pumping from the heart and thereby gives the maximum rest to them, which help to faster recovery of the heart and lung. This will also help to reduce the ventilator settings and inotropes to minimum, which will prevent the further iatrogenic complications like ventilator-induced lung injury and the inotrope-induced tissue ischemia. The intention of the ventilating the lungs while a patient is on ECMO is just to keep the lungs open, to prevent the atelectasis, irrespective of their contribution in the gaseous exchange. We keep the minimum ventilatory settings during the patient on the ECMO. In further our series, we will discuss more about this. ECMO can even sustain life independently in case of the cardiorespiratory arrest till the time of the underlying cause has been found and corrected, that is ECPR, extracorporeal cardiopulmonary resuscitation. It gives rest to the organ, which ultimately helps in faster recovery. In irreversible disease, it can act as a bridge to the device therapy or the to the transplant. ECMO also used in some innovative cases like reworming for organ retrieval from the cadavers, ELSR, for elective tracheal surgeries, ELE, CMO, etc. Goal of the ECMO to keep the patient alive without hurting him or her too much, to improve the tissue oxygenation and gas exchange, to allow normal metabolism while providing lung or heart rest at the rest, and to prevent the multiple organ failure, to avoid the iatrogenic damage due to the ventilator or the inotropes, to allow time for the reversible recovery of the lungs and heart by giving rest to them. Role of the ECMO helps to sustain life in case of the cardiopulmonary arrest, provide oxygenation and removal of the carbon dioxide, maintain mean arterial pressure, maintain tissue perfusion, decreases inotropic requirement and thereby reduces the toxic effect of them, decreases the ventilatory requirement and thereby reduces the ventilator-induced lung injury, rest to the lung and rest to the heart. ELSO, Extracorporeal Life Support Organization. It is an international organization of the healthcare professionals and scientists who are dedicated to development and the evaluation of the novel therapies for the support of the failing organ system. It was established in 1989. Head office is located in the on urban USA, and primary mission is to maintain the registry of the used Ecmo, also provided educational program, coordinate prospective studies, publish the guidelines, facilitate the techniques, teachings, and serves as a professional voice for the ECLS technology. In 1996 and 2001, ELSU published a comprehensive textbook on entitled Ecmo Extracorporeal Cardiopulmonary Support in Critical Care. It is well known as the Red Book. Ecmo Society of India. The society was started by Dr. Venkat Goyal and the Dr. Pranay Ojha at Mumbai with an intention to development and the spread of these novel technology in India in September 2010. It provides common platform for all those who are doing the Ecmo, maintain the data registry, provide education program, creating awareness and the training of the Ecmo specialist. The survival rate is more in the respiratory Ecmo than in the cardiac, and more in the neonate and pediatric than in the adult cases in the India. First of all, in India, Ecmo was started in the AIIMS Delhi. To summarize, Ecmo is a medical blink, is exciting, and it saves lives till the underlying organ like heart and lung recovers, and require experienced dedicated team and multidisciplinary approach is for its success. It maintains mean arterial pressure, gas exchange, and tissue perfusion without loading heart and lung, and thus provides rest to them. It decreases iatrogenic complication like ventilator-induced lung injury and toxic effect of the high dose of the inotropes. It should be considered early in the disease process after the assist device the normal conventional therapy phase and before the second organ failure takes place. So early decision to put the patient on ECMO is mandatory, so we can have the better result of the ECMO. The key factor of the success of the Ecmo depends on the time of the initiation. Coming to the history of the Ecmo. History of the CPB and Ecmo started with the crude cross circulatory support. A child's father was used as a biological heart-lung machine to use the heterologous biological oxygenators such as the explanted dog and monkey lungs, and finally to modern development of the membrane oxygenator and the centrifugal pump. Theoretical technology rapidly developed and newer sophisticated devices were developed. Ecmo run more successfully with the minimal complication nowadays. From 1960s to 70s was the decade a lot of development in the Ecmo occurred. In 1953, Gibbon used first artificial oxygenator and perfusion support for the first successful open heart surgery. Direct exposure of the anticoagulated blood to oxygen was successful. Direct gas interface oxygenator was developed during the era of the Danish, Morey, Crozon, Devol, and Rieg. And Colombo T has a first attempt at the ECMO. History of extracorporeal life support so thus become possible by 1950s development of the membrane oxygenator in the laboratory. Then in 1971 first successful case was conducted. 1972 first successful pediatric cardiac case was conducted. 1975 first neonatal case well known as the Esperanza baby was done. In 1975 to 89 trial in the ARDS, and there was 10% survival initially that increased gradually to current era of more than 60%. 1990s standard practice for the neonates and the pediatrics in the some centers, and 2000 standard practice for adult in some centers. 2009 publication of the Caesar trial with led to the significant growth in use of the ECMO for the ARDS cases, and recently in last COVID-19 era ECMO supported many life, and we could save the lives with the ECMO, particularly respiratory ECMO. Clinical journey of Ecmo started with the first successful case of Ecmo reported in 1971 by the J.D. Hill and colleagues. They used prolonged extracorporeal perfusion to support and save the life of young cyclist who had developed acute respiratory insufficiency after the trauma. That was first successful use of the Ecmo. Here this figure shows the first successful extracorporeal life support patient treated by the J. Donald Hill using the Bramson oxygenator foreground Santa Barbara 1971. See, this is very cumbersome things. There are so many instruments, equipments seen with the patient. It is the era of 1971. Evolution of the Ecmo mainly, Bartlett is the father of the Ecmo, and 1975 successfully applied the bedside ECLS device to treat the newborn with the meconium aspiration. This baby is called, I said, Esperanza baby. Of the development of the better membrane oxygenator was occurred at that time. Here you can see the first neonate Ecmo survivor, left side figure showing the Esperanza, age of 1 day in 1975, and this is the Esperanza at age of 21. Now she will be of more than 30 years. So Ecmo era started with this upper figure showing the more cumbersome unit, many instrument equipments, patient is surrounded by these. To the left side of the lower figure showing the moderate size of these, and now is a miniature, very sleek. We can keep the Ecmo in a bag. Such type of things happen over a period of the time. Landmark clinical trials for the Ecmo. First is the NIH trial between the 1975 to 1979, published by the Zapol et al. In 1979. Multicenter randomized trial of the conventional versus the Ecmo in adult patient with the acute respiratory failure. Trial was sponsored by the NIH, so it is well known as the NIH trial. There was no difference in the survival between the two groups, and hence trial was terminated prematurely. This trial remains as an ideal example of the how not to conduct the trial. There were several lacunae in the NIH trial. There were four main lacunae. One is the lack of prior Ecmo experience. Anybody involved in the study who had not any prior experience of the Ecmo. Second one is use of the high ventilator settings led to no rest to the lung, and ventilator induced lung injury was very high in this study. Another is the SCT targeted more than 200 seconds and responsible for the uncontrolled bleeding in the patients. All patients received the VA Ecmo, even though hemodynamically stable patients. So these are the lacunae which led to the failure of the trial. Then comes the Bartlett trial. In 1982, he published initial Ecmo experience with the 45 newborns with a respiratory failure. Ecmo used after maximum conventional therapy failed. The survival was more than 50% in patients considered to have the 90% mortality. Later on conducted the randomized trial using the extended study this is, and using the strategy of play the winner, comparing Ecmo to the conventional treatment. They had started two arms initially with the conventional treatment one and the Ecmo one. After death of one infant in the conventional treatment arm, they thought they should not use the conventional treatment when there is better facility available, and then 12 successful consecutive patients were successfully treated with the Ecmo. Morris PC IRV versus ECCO2R trial in 1994 compared the use of the extracorporeal carbon dioxide removal and pressure control inverse ratio ventilation in severe ARDS patient. Survival in the mechanical ventilation was 42% and in ECCO2R was 33%. Conclusion was the ECCO2R is unable to provide the protective lung strategy, and they didn't advocate the Ecmo therapy for ARDS, but at least they have done the study and given the idea. UK Ecmo trial. In 1996, 185 mature newborns with severe respiratory failure were randomized to Ecmo versus the conventional ventilator management. Mortality in Ecmo group was 30% versus conventional group was 59%. At 1 year follow-up, disability was also very less in the Ecmo group. Concluded that referral to an Ecmo center improved survival in mature newborn infants with severe respiratory failure. Now comes the Caesar trial. Caesar trial is in UK. Ecmo team in Leicester conducted multi-center prospective randomized trial of the Ecmo versus conventional ventilator in adult ARDS from 2001 to 2006. This was the landmark trial for the adult ARDS. 180 patients enrolled and trial funded by the NHS Health Technology Assistant Program, English and National Specialist Commissioning Observatory Group, NSCAG Group. Caesar studies entry criteria were adult 18 to 65 years of the age, severe but potentially reversible acute respiratory failure, Murray lung score more than 3 or greater, and or the uncompensated hypercapnia, pH less than 7.2. These are the patients included in the study, and exclusion criteria were duration of high pressure and high FiO2 ventilation more than 7 days were excluded. All patients with contraindications to limited heparinization was excluded. Contraindication to continuation of the active life support and intracranial bleeding patients were excluded from the study, and primary outcome measures were death or severe disability at 6 months post randomization. Secondary outcome measures were hospital indices like duration of ventilation, use of high frequency or oscillation or jet ventilation, use of nitric oxide, prone positioning, use of steroids, length of ICU, and length of hospital stay. Ecmo patients only, mode like a VV Ecmo or VA Ecmo, duration of Ecmo, blood flow and sweep flow were also observed. 6 months after randomization, activities of the daily living, quality of life, respiratory symptoms, cognitive psychological state, and lung functions were also observed. Results were survival in the conventional group was 47% versus Ecmo group was 63%. Benefit of Ecmo seen regardless of the age, duration of hospitalization before Ecmo, or duration of high ventilation setting less than 48 hours or more than 48 hours, hypoxic patient or hypercarbic patients, primary diagnostic pneumonia or other ARDS, and number of organ failed either 1, 2 or more than 3. All patients Ecmo benefited regardless of all these things. Improved 6 months survival without disability in Ecmo group was observed in this study. Ecmo in COVID-19 patients, a systemic review and meta-analysis published in 1922 in the Journal of Cardiothoracic and Vascular Anesthesia, that is European Journal. Pietro Bettini et al. Observed compared the survival rates of the patients with the COVID-19 supported with Ecmo and influenza patients supported with Ecmo. They concluded that Ecmo could be beneficial in patients with the COVID-19 with reported mortality rate was 39%. This systemic analysis provides clinical advice in the current era and ongoing pandemic. So in future also Ecmo can be benefited in various respiratory and cardiac morbidities and complications. Ecmo in India. Ecmo was used in post-op cardiac cases, especially in the pediatric cardiac surgical patients across the country since 2000. AIIMS Delhi was the first to use the Ecmo. Unlike the West, when Ecmo was designed, developed and perfected on respiratory cases, while in our country it could not march in similar direction. On account of intricacies of the perfusion technology and extracorporeal circulation, non-cardiac intensive care centers could not use this power of science due to the lack of logistics and the technical backup in initial phase. Now Ecmo is used everywhere in cardiac and non-cardiac. Rather, non-cardiac results are far better. Ecmo Society of India started in India in 2010 and organized first national conference on Ecmo in 2010 and released the book Ecmo Volume 1 Practical Manual. Ecmo Society of India provided a platform for the like-minded people to come close and work together for the cause of the science. The second national conference of Ecmo was conducted at Bangalore by Ecmo Society of India in collaboration with Narayan Hridayalaya. IACTA and ISCCT, Indian Society of Extracorporeal Technology. Nowadays, cardiac and non-cardiac ECMO are used in all over India with fair results. To summarize, history of ECMO started with 1953, Gibbon first successful use of the CPB and gave the idea of extracorporeal circulation. 1967, Colombo developed spiral coil membrane. 1972, Hill first successful adult ECMO. 1976, Bartlett first successful neonatal ECMO, who is called the father of the ECMO. In 1979, NIS study came. 1989, ELSO established International Society of Extracorporeal Life Support Society started. In 2001, ECMO established in India at AIIMS, New Delhi. Thank you.